we're going to take a few minutes and go through a few cases. I think it's fun sometimes to step back. We go through the x-ray analysis. We learn how to get the listings. We learn how to do our pattern analysis. We learn how to adjust, when not to adjust, and we learn how to adjust. We understand the neurology. We go through the basic KCUCS program, and I think it's a great program, but I think it's really awesome to step back sometimes and just kind of look at the fruit of our labor, if you will, kind of get an idea of, okay, this all sounds good, but what happens once you apply it? So I wanted to pull out a few cases here, and I have to say that these are not extraordinary cases. They're just cases that I thought were interesting because they were documented, and I thought that we'd like to share them. The first case was I believe she was an 18-year-old girl, maybe had been 20. No, I think she was an 18-year-old girl, and she came in with low back pain. And so through the course of going through her case, we looked at it and we determined, of course, that we needed to get her head on straight. We found what we see right here. The neutral lateral was performed prior to KCUCS Upper Cervical Care, 7/11/2011, and of course the interest complaint was low back pain. She'd been having low back pain for a long time. This was not something that just came about. This was something that was more chronic in nature, which is kind of funny for an 18-year-old, but she had been having it for the last few years. As a matter of fact, this report or this study was written up, and we possibly will get this published. It has already been written up. It just needs to be tweaked to be able to do it. It's just a matter of the stick on the desk needs to be done. So anyway, this is the first film. And then on the first visit, before we actually got started with her, we went through and did an HRV. So the HRV, heart rate variability, this is an instrument that we use to measure the autonomic nervous system. We want to see a couple of things. There's a number of things we can see from this, but two things we primarily look at is this autonomic activity index, autonomic nervous system activity index. It's a pretty good broad measure of how healthy the autonomic nervous system is. And then, of course, we want to see the balance. We want to see if the parasympathetics and the sympathetics are balanced. The ideal position for this dot would be right on smack dab on top of that 9, if I could say it that way. Anytime you get outside of that, then we're moving into a place of an unbalanced or imbalanced autonomic nervous system. So that's how she presented right before the adjustment. This is the second neutral lateral that was performed 4 weeks following the initiation of KCUCS Upper Cervical Care, August 8th, 2011. Low back improved significantly, but not completely resolved. So this is kind of unusual. If this is a simple case, low back pain, usually you'll adjust them, the back pain's gone, everything's fine. Of course, we're not just adjusting for symptoms, but the fact is you get the upper cervical right, and you get it balanced, and you establish a normal center of gravity. These things just straighten up generally, unless you've got a little bit more going on. And that's one of the reasons why I shared this case, is because she did have some imbalance going on in the autonomic nervous system. So it wasn't just strictly a mechanical problem, although that definitely was a portion of it. Our second HRV actually looked like that, and you can see on the one side the activity index actually dipped just a little bit, but we started moving into more of a balance, and I thought that was a kind of a neat thing to show, because we can see that actually through the process of getting well and restoring health after somebody's getting clear, the body's going to go through changes, and sometimes when you look at it and you take a snapshot in time, it's going to look a certain way. Like, for instance, if you adjust somebody today, they may come back in 3 days and say, oh my goodness, after I felt great for 3 days, and now all of a sudden my hip hurts. And then you ask them, well, were you having hip pain before? No, I wasn't having it, but I used to have it like 10 years ago. Well, there you go. They're going through a normal process of retracing, but if you took it at one slice of time, you would get incorrect information. You'd think, oh my goodness, what I did was did something detrimental, or we're going the wrong way, or we need to do something different. But you need to understand, or we need to understand, I put myself in that category, I'm pointing fingers at myself, we really need to understand the physiology and how the patient's walking through situations so that we can better coach them and stand firm on that rock and understanding when the line is clear that the patient is healing, and that's really our goal, is for the patient to be clear so that they can heal. Okay, so that's the second one. This was our third neutral lateral, performed 3 months post the initiation of KCUCS Upper Cervical Care, October 24th, 2011. All symptoms completely resolved. I thought this was a pretty awesome post picture. And here's our 3-month, our autonomic nervous system activities back about where it was, but the good thing about it, now we're looking at a balanced sympathetic nervous system and parasympathetic nervous system, autonomic nervous system, which is your parasympathetics and your sympathetics. You remember we talk about in the seminars how when somebody's sympathetic dominant, it can really be the first stage of setting things up like messing up the HPA axis, the adrenal fatigue, and a whole host of things that can even run the gamut of thyroid problems, insulin problems, all kinds of hormonal issues. There's a lot of issues that can go on when the autonomic nervous system gets imbalanced. And let me just say this, when we're dealing with upper cervical, I really believe there's 2 major factors that we're really dealing with. Number one is there's just a pretty straightforward center of gravity issue. When that head's not sitting in the groove properly, it shifts the center of gravity in such a way that the vestibular apparatus within the brainstem is going to make necessary changes in the posture, changes in the hip, short leg, changes in the shoulder heights, changes in different areas of the body to compensate for that wrong position. So therefore, when we put the head right back in the normal position, now we start going into a balance, and sometimes these compensations begin to unwrap and unravel as they work back into normal. That's the reason why, from a mechanical standpoint, we will have retracing and we will have a visitation of old symptoms. I remember I had a patient one time that came in and had all kinds of problems that weren't, it's kind of funny because we really, in our clinic, we attract, I showed a low back pain patient here, but we attract really very few like back pain, low back pain patients, even neck pain. You'd think we'd get more than we do. We seem to attract the autoimmune, thyroids, the adrenals, and a lot of skin stuff and a lot of stuff like that, which is pretty cool. I like to see those things, those people respond to that. It's really awesome. But anyway, but this guy comes in, and I can't remember what his condition was. I know he had a seizure and some other stuff. But anyway, we had adjusted him. And right after the adjustment, he walked out. Actually, he rested, rested for his time to rest. And then he went out to his car, and he started feeling his pain on his foot. And then he went home, and he didn't think anything about it. And then 2 or 3 days later, that pain got not real intense, but it was enough that it was bothering him. And then over the course of the week, the pain went away. Well, it's very interesting. He comes in the next week. I had been seeing him for maybe 6 to 8 weeks, maybe 10 weeks. I don't remember. But it had been a course of time where I was now checking him once a week. So he comes in, and he said, "Hey, Doc, after the adjustment, I said, my foot really started hurting really bad." And I'm telling you the story because this is one of the weirdest retracing stories that I've heard. I said, "Have you ever had that pain before?" Because the line was clearing, and he was straight, and it looked good, and all the other factors were doing so much better. I really felt like he was on the right track. So anyway, he said, "Yeah, I did, as a matter of fact." He's about 48 years old. He said, "When I was 17 years old," this guy's a big, burly guy. He said, "I was helping somebody," and mainly he was doing it, "pick up a 350 Chevy engine, engine block, and I dropped it on my foot right exactly where that pain was. And I had that exact same pain for a long time, and it finally just went away." So I thought that was really weird because we adjusted him, and he was working through the process of retracing and restoring his health, and he actually retraced an engine block falling on his ankle. So that was pretty interesting. So anyway, let's look at the third. Let's look at all 3 of these together. This is pre and post KCUCS Upper Cervical Care. Here's our dates: 7/11/11, 8/8 to 11, and 10/4 to 11. And we have, if you see the first one right here, you can recognize that curve is not normal. This one's looking a little bit better, and of course that's looking really good. That would be a good film to show as a normal. There's a slight anterior weight bearing, but you can't complain about that too much. That's a pretty good one. Okay, let's shift gears a little bit. We did a study one time. This was a number of years ago, maybe 10, 15 years ago, where we brought people in and we did a flexion extension x-ray. And then we started on their first adjustment. Like they come in as a new patient, they weren't in for the study, they just came for a new patient. I said, "Hey, we're doing a study here, would you mind if I do a flexion extension x-ray?" And then, of course, we'd do that. If they consented to it, and everybody consented. If I don't remember anybody not consenting, maybe they did, but I don't remember. But anyway, so then we put them under care for KCUCS Upper Cervical Care, nothing else, no, not even as much as any, muscle work, no 9 points, no, nothing but upper cervical care. That was it. And so at the end of 6 weeks, we did the flexion extension, x-rays, repeated that procedure. We measured those films by Penning's method. If you haven't seen that, that's really a neat thing. It's really difficult to do. I haven't figured out a way to do it on digitals. But with flat films, there's a specific procedure of doing that that's really neat. You can look that up on the internet, Penning, that's Penning's. The guy's name is L. Penning. He's written a number of works, and really a well-known radiologist, come up with a lot of really great things. But what this Penning's method does is it gives you intersegmental motion. So it shows you what the motion should be. And each segment has a specifically defined amount of motion that's supposed to happen. And given, for instance, you're between C6 and C7, there should be about 20 degrees of motion. And but if you get up between C2 and C3, there should be about 12. So there's different factors. Now, I don't have any of those percentages here. If you want information on that, contact me and I'll see to get that information to you. So, but anyway, on this particular case, or in this particular case, there are multiple people in the study. If you look up here, these are the females. In the beginning, we had 31 in the hypo at this level, C2. We had 31 people out of the study were hypomobile on Penning's analysis, and 4 were hyper, and 23 in the normal. After the 6 weeks, they went from 26 in the hypo to 29 in the normal. You see how that increased, and then both the hyper and the hypos decreased, which is really neat, and the normals increased. And if you look all the way down here, you see that trend happening. But you see it really happening big time, C5, C6. Look at this. 45 were hypomobile before they started care, and only 11 were found in the normal zone. And then we had 1 that was hyper. So after the 6 weeks, when we compiled the data, we found that 31 were now in the hypo as opposed to 45, and 24 went to normal, 11 to 24. This is fantastic. And then right down here, C7, C6, C7, we went from 28 in the hypo to 22. We went from 3 to 6, or 3 to 9 in the normals. This is really great. The females actually fared a little bit better, quite a bit better than the males. We have different theories for that. One of the reasons I believe it happens is for the same reason why females are more susceptible to having injury in the lower cervical spine than males during rear-end car accidents. And the reason why that is because the weight of the head versus the circumference of the lower cervical spine is smaller in females than it is in males on average, and it just is more susceptible to injury. So I also think it's more susceptible to, once the correction is made, for corrections to be made. I don't know that, but that's just a theory that we believe. I mean, that's an idea that we think could be correct. So now on this one, there's not a lot to see there. Okay, so 56-year-old male presents with diabetes mellitus, diabetic neuropathy. Patient comes in following an insulin-resistant talk at Kessinger Specific Chiropractic Clinic. We brought people in and we said, hey, we're going to tell you about insulin resistance. And then we explained how it works, what it is, and where it comes from, and what we need to do to resolve it. He stated that he had diabetes for approximately 10 years. His blood sugar levels are never below 200 and are usually above 300. Just as a side note, they found the New England Journal of Medicine has published 2 studies showing that the more tightly you try to regulate your insulin, the more it's consistent with dying early and having problems. And the reason why is because the insulin, up to a point, becomes even more toxic and more caustic to the body than the blood sugar itself. So they find that if they ease that up and try to keep it in the 150 zone to 180, it's much healthier for the patient than trying to really ratchet that thing down and keep that blood sugar down into the about the 100 mark. Of course, the best thing is get to the root cause of it, and I like what my dad used to say. He used to say that he felt like diabetes was should not be considered a disease, but a disorder, because it's completely reversible. And I can attest to that. We've reversed this on many people, and it's what a wonderful thing, because when a person is diagnosed with diabetes, this is just statistics. These are just statistics. That person is said to that they will live a third less than they were going to live, and they're going to be more beset with problems like kidney problems, maybe blindness, even amputations and different things because of all the damage. Because diabetes, when it comes down to it, is an inflammatory disorder, and it really messes with the small arteries. And anywhere small arteries are, there you're going to have a problem. That's why you have it in your hands and your toes and your eyes and different places like that. Even these people, they say now Alzheimer's is considered type 3 diabetes. So we really need to get a handle on this. And I'll tell you one more fact. They have described that 50% of the U.S. population by the year 2020 will be either diabetic or pre-diabetic, and that just blows me away. Now we're seeing kids used to never get type 2 diabetes. Used to be, people turn 25, 30, or you'd see it really happen around 40 or 50. But now we have children that are 8, 10, and 12 years old developing type 2 diabetes. Now you can say, well, that's because they're just drinking all the sodas and they're doing this, they're doing that, and all the other things. But really the fact is they're doing studies, and they find that how the mother treats herself from a nutritional standpoint, and I'm sure from a self-fixation standpoint, how she treats herself during the pregnancy has a lot to do with the sensitivity that cells in the body, particularly the liver and the skeletal muscle cells, are going to have to insulin. So the more resistant that you are to insulin, it doesn't really matter what you do until that's corrected, you're going to develop these problems. So I didn't go too far on that. I just want to give you a little heads up that I think it's good for us to understand this condition. And also, keep in mind, I'm an upper cervical doctor, and the foundation of everything we do is our upper cervical. We have to get people clear, no matter what that looks like. We've got to get people clear so they have a free flow of life from above, down, inside out, so the body can act normally instead of abnormal. This is abnormal working, but I think it's good to understand this, because when you're talking to patients out there, believe you me, they want to know that you know what's going on, and they will flock to you when you can produce that and also produce the results. So a patient reports that he quit taking anything for it. Man, that's my kind of patient. Tough. There you go. He's going for it. He also reports moderate to severe pain in the right foot, as well as numbness and tingling in toes. Of course, this is the diabetic neuropathy. We did a blood test on this patient. We do blood tests in the office. BJ did blood tests. We do blood tests for the purpose of seeing where people's at, because I love to do upper cervical care and just see what happens after we apply the care. So we look at this as HDL cholesterol is at 34. A man should have HDL cholesterol at least at 40, or it really spells some pretty big troubles. Of course, his glucose is way out. We already knew that. No big deal with the creatinine and BU in there. That's just a good kidney function right there. The sodium is at 133. That is a huge amount of adrenal fatigue. Well, adrenals and blood sugar, they're cousins. They work together. So if one's out of order, the other's got to be out of order. So this is actually going to be a good marker to see if the patient's getting better after we apply our care. So the chloride is low. That's another symptom of the adrenal fatigue. Man, he's got it bad. And look at this hemoglobin A1C, 9.9. That is off the charts. You just can't live very long keeping that. And the liver enzymes are a little low, so he's got some liver congestion, some other stuff. So basically, that's what we're looking at right there. Let me look at the uric. Okay, we're good there. Then it's ferritin. This is iron storage, but when somebody's in bad trouble and they're in a free fall of a chronic degenerative disease, a lot of times you'll see that ferritin bump up over 500 and more. So this is really not a great sign for this guy. It does not look good here for the home team. So anyway, he comes in. We do the HRV. This is for the adjustment, and look how low that autonomic nervous system index is. And that's lower than 20. That's almost not breathing. That's really bad. And his balance is so bad that it won't even show up on this graph. There's no category for it because his autonomic nervous system is working so low, it won't even pick it up, it won't even measure it. So this was May. Look at this. Now I'm going to back up and say, look at this. This was February of 2011, and this was May. Look at the change, and I got to tell you, this guy got his life back. What did he do? He did two very simple things. Some people don't like it, that we advise this, but guess what? It was part of saving this guy's life. One thing is we got him under upper cervical care, and he basically stayed with it, and I put him on a very basic, what I call modified paleo diet. Basically got him off of grains, got him off of junk food, had him make sure he was eating meat and vegetables and really nothing else, and the guy complied with that very well. And so that was all we did. We just got him off the grains. We got him under upper cervical care, got him clear, and just a fantastic thing happened here. And as you walk through this process, you can see where his weight went from 255 down to 222. So he lost 30 pounds. He wasn't trying to lose weight. He was just simply eating right, and he was losing weight. Also, I think it has to do with the fact that getting clear will affect the body's ability to regulate the insulin better. And when you have so much insulin pumping out there, it increases your insulin resistance, which is going to hold on to the weight, so that alone is going to help him lose weight. So there's a lot of issues going on. His urinalysis, we were doing urinalysis on him. Anytime, you're not going to see glucose or sugar in the urine unless it's actually at 180 or above in the blood. In other words, if somebody has a blood sugar of 150, it's not even going to register on the glucose in the urine. So you see the first few times, February 7th, February 10th, February 17th, he had blood sugar in the urine. I'm sorry, he had sugar in the urine. And then after that, of course, that dropped out. And you can see how a lot of these other things really, really got better through the process, which were, really very, very happy for him. He had a good result there. And so let's see here. Okay, let me back here. Foot pain. You can see this is him writing his notes each day, and basically he's just talking about how his blood sugars come down by itself. It's in the zone of about 100 to 120 by itself. Here's what our adjusting chart looked like. It's kind of funny, but this is how I do my charts. Here's my pelvic balance, 12 millimeters short left leg on the left. In his patterns, I found 5 breaks. You'll learn about this when you go through the pattern analysis and pattern analysis workshop. So I have 5 breaks in my pattern, so I know that each time I see him, that's the breaks I'm looking for. So I'm going to come through here. We did an ASL adjustment. I grade my adjustments 1 to 5. If I feel like it was a really excellent set, couldn't be better, I call it a 5. If it was a really good solid set, I'll call it a 4. If I'm just fairly impressed with it but not impressed that much, I'll call it a 3. And if I feel like it was a push and a shove, I'll give it a 2. If I don't feel like I got a good set, I'll do that, and so on and so forth. So very interesting. Down to July 25th, 2011. Things were sailing along pretty good. His foot was feeling pretty good. Things were going pretty good. After that adjustment, and this 2 weeks later he came in, he said his foot started tingling again. All the diabetic neuropathy signs came back. And what happened in retrospect is I simply adjusted him when I should have really waited. I mean, that happens. And so I adjusted him too early. It looked like he was in pattern, but I really should have let it go. And because I adjusted him at the wrong time, we didn't get a good set on it. It actually returned some of the symptoms, because guess what? I put him in subluxation. But then, of course, a good thing, we got it back in shape the next time. That's the reason why I tell patients this. I say, they said, "Doc, I don't want to come back to you because I heard after the last time I see you." My response to that is, you should be running to me so I can, if I did screw something up, I can fix it. I know I'm trying to be funny, but it really is true. So, okay. As of 8/22/11, blood sugar levels averaging between 100 to 110 with some readings in the 90s. This is remarkable. No more pain in the right foot. Tingling, that's after the bad adjustment. He got back on track again, by the way. But anyway, tingling in toes of right foot much improved. Energy level much improved. Sleeping much better. And look at this. This was I believe that was the first one. See this February 7th? That's what we're looking at. Look at that hemoglobin A1C at 9.9. Sodium at 133. Look at all that. Triglycerides. And, okay, so that's just a blown up view of it. 9.9, 133. You can see all that. And this is the post right here. Hemoglobin A1C down to 5.8. Do I hear a cheer? Anything under 6 is considered normal. I like to actually see it under 5.7, but I'm not going to complain too much about that. Look at the sodium. 136 is still a little bit low, because sometimes those adrenals get so wiped out it just takes time for them to rebuild. It doesn't, it's just a process. So 136 is much better, but it's still a little bit lower than it needs to. Of course, you can see the glucose is low, the HDL cholesterol's come up. So everything looks like it is much better. He's not just telling us it's much better, but the HRV looks better. The blood test looks better. His readings are looking better. He's feeling better. This right here was what I would consider to be a very successful case. That's the reason why I'm going to show it to you. Here's the sodium is 136. Look at the hemoglobin A1C, 5.8. It was 9.9. I'm just going to tell you something. You cannot live very long with a hemoglobin A1C, or you can't live very long very good. And I would say, and I told this guy when he first got started, look, you got to be serious about this. You know, make sure you keep your appointments, make sure you're staying clear, and stay on that modified paleo. I mean, you need to stay on that, stay away from the grains. You got to get serious about this, because I said, if you don't, looking at you right now, this does not look good. And I don't know, I'm not your creator, so I don't know how long you're going to live, but I will tell you this, it does not look good if you don't make some changes. Okay, I just want to show you a few things. These are a few pictures from, I think, some of Scott Rose's work, which I think is fantastic. Here's the DENS right here, and here's the atlas. Here's the foramen magnum. What we're seeing here is right in the upper cervical spine. Scott Rose is doing some wonderful work on there. He's an AO doctor, and that he's showing that there's blockage, or they can believe blockage, in the cerebral spinal fluid here at the base of the brain, right where it goes right into that upper cervical canal. The cerebral spinal fluid is very important for getting the junk out of the brain, for getting for reducing inflammation, which is the whole ball of wax almost in the brain as far as brain health. It helps keep the minerals balanced. There's so many things that cerebral spine, and it even helps cushion the brain, if you will. And there's so many things that are necessary. When you get that impinged, it can really cause some problems. There's even been some people talking about links between cerebral spinal fluid flow being blocked here and multiple sclerosis and things like that. We know that upper cervical has been successful for that, and it's nice to kind of know what could possibly be doing that. Okay, this is just showing how far the olives have come down. That's actually below the foramen magnum. That's pretty incredible. Look how low that's sitting in there. Those tonsils are sitting in there. Oh my goodness. Oh my goodness. Scott Rosa did a webinar for a couple of us one time, and he was explaining that the medulla, if you think of an elephant sitting, or you can think of a trampoline. Think of a trampoline, and you see how that. Just think of the dentate ligaments being like, I'm sorry I'm having trouble explaining this, but I'm trying to get this out because I think it's important, that the dentate ligaments kind of act like a trampoline in that they hold the medulla up, where it's supposed to be. But if you can imagine an elephant sitting on the trampoline for any time at all, it would loosen the trampoline itself, and then it would begin to sag. He said that's exactly what happens during an accident or some trauma in that upper cervical area. Those dentate ligaments can actually get strained to such a degree that they just kind of dip down, and that causes the contents up here to go down lower. And of course we know that then that's going to be more susceptible to problems because of the upper cervical subluxation, primarily when the head's not on straight. This is going to be a problem. I think another issue for the upper cervical subluxation, and I think probably one of the main issues, I think the two main issues, let me just say it that way, that we're dealing with for all the pathology and all the problems associated with the upper cervical subluxation are related to the cerebral spinal fluid blockage, and I believe we also have blood flow disturbances, whether it's on the arterial side or the venous side. We have venous blockage, and we have some just a damming up of the venous flow, and then we have some blockage of the arterial flow going on, messing with the lower contents of the brainstem or even the upper higher contents of the brainstem, and causing a lot of different problems. So I know there's other issues going on, but I believe these are the two majors, because these are the two things that can really touch the autonomic nervous system. And from our work looking at heart rate variabilities, I believe that we're really majorly affecting, you've already seen a couple of cases here, we're majorly affecting the autonomic nervous system. Okay, so yeah, you can see how far that went down. Just look at those cases. It's incredible. Look how here's the atlas right here. This posterior arch right here is foramen magnum here. See how low that's hanging right there? That's not good. Wow, look at that. Pretty impressive stuff that Scott Rose has done for us. We really, really appreciate his work. He's just done phenomenal work in the upper cervical world. Here's some more right here. Just look at these. Now I want to take a moment and look at this. I want to show you, because if you don't look at this, you wouldn't realize, all the stuff that's happening when people are in subluxation. It's just incredible. Look at this. Look at this head movement. Oh boy. Yeah, look what's happening down in that lower part of the neck. Oops. I shouldn't have done that. Okay. Look at that. Look at that. Oh my goodness, that cannot be good for the brainstem. Look at that. Now, you would take a normal lateral film and you'd say, oh, well, it's a reverse curve. Let's take a look at it and see what we can do. But there's a lot of things going on in there that you just simply can't see from a flat film. This is a DMX, by the way. Oh, wow. Yeah. Oh my goodness, that just looks like it hurts. Not hurts, but I'm going to tell you that right there has got to be devastating for the function. Think what's going on with that spinal cord. Think what's going on with that brainstem right there. And this person, very difficult for this person to be well. This person is going to need better upper cervical care for a long period of time to get some kind of stability in that. And you know what? It may never look great, but with upper cervical care you can at least get it in its best possible position. This is a case study that I published a number of years ago in JMPT. Dr. Bo Rochester actually morphed this, and I thought it would be fun. Whoops, let me see. I thought it would be fun to watch a few of these. That's a pre-post. I think it's about 5 weeks. So let's do it again. So let's start here. That was what it looked like before care. And this is not after care because she stayed on care longer than that, but this was 5 weeks later. That's a pretty good change. And this is a case, this is one of Dr. Kirk Erickson's cases. He's the author of Cervical Subluxation Complex, Review of Chiropractic and Medical Literature. So watch, whoops, I actually scooted that ahead, sorry. Let's hit this button. Okay, that's a pretty nice little change. And this next case right here I think is neat, because this shows this is a lumbar disc. See this disc right here? And this is after upper cervical care. It's my understanding that it was 13 weeks, but I'm not completely sure. It wasn't my case, and I could be wrong on that, but it was some time after that, and this is the pre-post. Look at this. Look what's going on with that disc. This is pre-post upper cervical care. Isn't that exciting? Man, that's exciting. That's wonderful. That's kind of what we're showing with that study we did with the x-rays that you saw earlier in this presentation. I was talking about how when we get the upper cervical spine right, it's actually making improvements in the lower cervical spine, but guess what? It's also making improvements in the lower lumbar spine, because the upper cervical area, when you understand the root, which will be a presentation in this x-ray package, when you understand the root, you'll understand that when you get that upper cervical right, you get the head sitting in there right, the root can be in a balanced position. When the root is in a balanced position, the whole rest of the spine can follow and take on a normal position. Of course, we have our pattern analysis we use right here. We have specific methods for drawing it, and of course you see pre-post on the leg lengths and so forth. We believe in doing that. And we have a specific way of actually of marking these patterns, which we detail in the pattern analysis. If you've not taken that workshop, I highly encourage you to do that. We'll also, if you've purchased the x-ray program that goes with this, we're going to have also very soon, and hopefully by the time you've gone through this, we'll already have the pattern analysis workshop DVD presentation that you could purchase as well. And I have to tell you, the pattern analysis is the cornerstone of everything we do, because it tells us if what we did was right, if we're on the right track, we need to adjust, we need to not adjust, we need to babysit. What do we need to do to help that person get well? And I have to tell you, the pattern analysis, the way we teach it, we learned from Dr. Duff, and Dr. Duff actually took it to the next level after BJ had it, and it is probably one of the most scientific thing as far as reproducible thing that we can do in our office, that with the x-rays and so on and so forth. It's solid science, and if you learn how to do it, you'll absolutely get addicted to it, because it's a fantastic way to help sick people get well. Okay, this is the end of the presentation. I've had a lot of fun. I hope you get a lot out of this work. Bless you for moving forward and helping sick people get well.